go on to Dr. Rashmin Gandhi, and he's going to talk to us something so very critical and essential in diagnosing corneal sensation as a localizing sign in neuro ophthalmology. On to you, Dr. Rashmin.
Thank you so much. Thank you, Dr. Chitra. It's always a pleasure to be part of these meetings where you make it so. The topic that Murli has given me is a very, as Prem was saying, a lot of times we have a topic where we would have to go ahead and search and topics which are often less talked about. And this is one such topic where corneal sensation and its role in neuro-ophthalmic uh, localization.
Yes.
So let's have first some of the bases of the corneal sensation. Cornea is the sensory part of cornea is one of the densely supplied tissue in the eye. The sensation from the eye is carried by the long ciliary branches of the nasociliary nerve. The efferent reaches the pons to the trigeminal nerve, the nuclei, and the efferent comes from the facial nerve. And this leads to what is known as a blink reflex. So when you touch the cornea, cornea is really sensitive to touch. It generally causes pain because of the mechanoceptors which are present there. And it's also sensitive to various other stimuli, sensory stimuli. So the efferent arc is through the trigeminal nerve and the efferent is in the facial nerve. The couple of important points and probably which will help us understand this blink reflex. One is the cornea has what is known as the subbasal nerve plexus. So in other words, this plexus has a wide range of area covered by a single nerve fibril. So on the cornea, it's difficult to really localize a lesion, as if, if there is an intranasal loss of corneal sensation. Does it mean anything? Not much. The second important point, which we'll talk about in the end of the talk, is that when these nerves enter the cornea, they are myelinated. And just after the limbus, they lose their myelin sheath. So with this background, let's look at the value of this blink reflex or corneal sensation. One more point, how do we really test this corneal reflex? There are two ways. There is a quantitative way and a qualitative way. The quantitative way uses the esthesiometers, like Bonnet esthesiometer. I have no experience of using them. And the usual way in the clinic is using a sterile cotton tip and testing the various areas of the cornea. Thing to remember, especially for the residents who are listening to this, is that we need to make sure that we go from the side or from below, because if we go directly there, the blink reflex is actually stimulated because of the menace reflex. Now with that, let's look at some of the cases and see where the corneal reflex testing would have helped us to differentiate or localize the lesion, because that's the central point of the talk. So here is this young man who, if you see, he was complaining of diplopia in the left gaze. And see, patient looking to the left, there is a complete loss of abduction of the left side, and the right side, there is a nystagmus. In this patient number one, you see here as well, there is a gold weight implant, which has already been implanted in the upper eyelid, implying that patient had leg ophthalmos. So here is a patient who has a 6th nerve palsy of the left side with a 7th nerve palsy and a nystagmus of the right eye. So that's patient number one. Now let's look at patient number two, and then we'll differentiate and see how corneal reflex would have helped. So here is patient number two. Here again, you see here the right eye had a gold weight implant. Now let's look at the ocular motility. So here is a patient looking to the left, and you'll see that the left gaze is fine. And here you will find patient looking to the right. Right eye is not abducting, left eye is not abducting. So we have seen two patients, both had an abduction limitation in one eye and also the 7th nerve problem in the same eye. But in patient number one, you had nystagmus of the other eye, but the adduction was normal. Here in the patient number two, there is limitation of adduction, implying there was a gaze palsy to the same side. So would corneal sensation be of any help? Would it solve this puzzle of localizing lesion between these two patients? Well, it would. Patient number one, you localize the lesion to CP angle, while here, patient number two, you localize the lesion to pons. This patient has a gaze palsy. Remember, the sixth nerve nucleus is in the pons. Seventh nerve makes a loop around the sixth nerve nucleus of facial colliculus, and the sixth nerve nucleus generally acts as a gaze center to the same side because of its proximity to PPRF. So if you look at the now look at the diagram, we find that sixth and the seventh nerve are close nearby in the pons, implying that in patient number two, there is a likelihood that the corneal sensation would be normal. Versus in patient number one, where you localize the lesion to CP angle, you find here that this is the triangular space is the CP angle between cerebellum and pons, and you find the fifth nerve being here. So, and in this CP angle space, as sixth and seventh nerve progress, and also the eighth nerve, they all would be clumped together. So, loss of corneal sensation is much more likely in patient number one versus patient number two. So, in other words, you can differentiate between the lesion of CP angle and the pons by corneal sensation, apart from obviously the ocular motility. In fact, in CP angle tumors, there is a possibility that, especially schwannomas, that corneal sensation can be the first sign of these tumors. So patient may have headaches and tinnitus, and the only sign initially can be a loss of corneal sensation. So that's scenario number one, where corneal sensation can be of use to differentiate between two anatomical areas. Now let's look at the second area where all these nerves are bunched up. This is a 42-year-old gentleman who had uncontrolled diabetes, complained of diplopia in the left gaze again. And you find he was told that, oh, this is, and you see here there is again a limitation of the abduction in the left eye. He was told that, oh, this is because of your loss of blood sugar control, and it will become all right. However, if you look at the ocular motility a little more carefully, you'll find that there is also limitation of adduction, minimal limitation of adduction in the same eye, and also the elevation is down. This patient, again, a corneal sensation would be lost. You localize, patient's visual acuity was fine. So here we have a patient who has a sixth nerve, third nerve, and fifth nerve being affected. The possibilities of these three nerves, sixth, third, and fifth nerve being together affected, the possibilities are it can be within the orbit or it can be within the cavernous sinus. Now, if the optic nerve is normal, you localize this to cavernous sinus. Let's look at one more patient of a similar kind of little more severe limitation of ocular motility. Patient had ptosis. You see here, there is a limitation of adduction of the right eye. You find that the abduction seems to be okay. However, if you look at the eye carefully, it moved very slowly, and there was a limitation of depression and elevation. Whenever you have this, you look at the involvement of the fourth nerve, you'll find that there is no torsion of the same eye when patient is looking from up to down, implying that third and fourth nerve both have gone, and also the sixth nerve. This is the patient again where corneal sensation, though I don't have a video, would have been affected. Again, you localize it to the cavernous sinus, and this patient actually had a cavernous sinus lesion, which turned out to be aneurysm. Versus, so here is a cavernous sinus diagram, especially helpful for the residents. And you find here that the sixth nerve is within the substance of the cavernous sinus, while the third nerve, the fourth nerve, and two divisions of fifth nerve are all bunched together. So cavernous sinus lesion would have effect of all these nerves, and sometimes also effect on the sympathetic system. Versus a patient who had severe ptosis and complete limitation of ocular motility in all gazes, and this patient also has loss of optic nerve function, implying that you now are localizing this lesion to orbital apex. So in other words, the second area where corneal sensation can be an adjunct to your diagnosis, and in conjunction with sensation testing in other areas of the face, would be this cavernous sinus orbit and supraorbital area. You find here in the diagram that V2 leaves before it reaches the orbit. If the V2 has been affected, apart from other cranial nerves, you localize it, so corneal sensation and also loss of sensation in the lower part of the face. You localize it somewhere outside the orbit, so in the cavernous sinus. But if there's a loss of corneal sensation and other nerves are involved, you know that it's either superior orbital fissure or orbital effects. And this is a diagrammatic representation of corneal sensation. Ophthalmic division of trigeminal nerve, or V1, is where cornea also is included, corneal sensation is included, while V2 and V3 are lower. So that's about localizing lesion using corneal sensation as the sign. Now, can it be false localizing sign? False localizing sign generally be associated with a sixth nerve palsy, especially in raised intracranial pressure. However, when I was digging the literature, I found that the fifth nerve also can sometimes, a fifth nerve, loss of corneal sensation can also be a false localizing sign, especially in somebody who is having a tumor in the CP angle or near the brainstem. The reason that it can be a false, so if somebody has, let's say, a left-sided CP angle or brainstem tumor, we expect that the corneal sensation will be lost on the left side. However, if the tumor is large enough, or if it's pushing the brainstem to the other side, then there is a possibility that the corneal sensation will be lost on the right side, and hence loss of corneal sensation in these scenarios can be a false localizing sign, localizing to the area where you don't expect to localize. And this is the last part, as I mentioned in the beginning, that these nerves are myelinated and they lose their myelination just after they enter the cornea. So can it be used as a marker for multiple sclerosis? Where there have been, I found studies where they really mentioned that corneal confocal microscopy, they found a correlation between density of corneal nerves and activity of dendritic cells and a disease activity in multiple sclerosis. In other words, they found that multiple sclerosis can have a loss of density of corneal nerves, especially in certain various multiple sclerosis, not all, and not all of these patients would exhibit, however, the loss of corneal sensation. In other words, maybe a little more sensitive quantitative test probably would uncover some of these loss of corneal sensation, which I found interesting. These are many of these were recent papers, so maybe a little more detailed or a little more larger study may help us to have corneal confocal microscopy, the nerves within the cornea, and hence the corneal sensation be used as activity of a disease progression in multiple sclerosis. Please remember, since this talk was limited to localizing it in a neuroophthalmic diseases and only for 7 to 8 minutes, so I've not covered, let's say, neurotrophic keratitis or loss of corneal sensation in aging or in diabetes mellitus. So in other words, corneal sensation, testing corneal sensation is an easy enough test. It can be used as an adjunct to localized lesion in neuroophthalmology. I thank Dr. Chitra, Dr. Murli, and entire team at Eye Foundation for inviting me here. Thank you so much.
Oh, amazing talk as expected. Murli, anything to ask before we go on to our last speaker?
Yeah, just a quick comment, RAG sir, that sometimes you see in patients with unilateral LASIK or in patients who have had multiple episodes of herpetic this thing also, herpetic keratitis, they also tend to lose corneal sensations. And when these patients actually develop some kind of a nerve palsy, we get a little bit confused. That was a
Correct.
more of a comment.
Yeah, absolutely. Because as I said, corneal sensation can be lost in some of the local diseases as well. Even stuff like dry eyes and diabetes. So it is basically, when we look at the fellow travelers, is where you say that, okay, this is where you localize. But isolation, just the loss of corneal sensation, may or may not have an impact on, unless, as I said, only reference, and I'm happy to learn from others, but only reference I found that corneal sensation as the only sign, I found that was part of CP angle tumor.
Any comments, Dr. Drew, on the last two talks?
That was a great talk. I think in addition to its utility in localization, damage to the trigeminal nerve, it's the only sensory nerve other than the optic nerve that's going to lead to vision impairment. And so these patients develop neurotrophic keratopathy, which we now have treatment for with the recombinant neurotrophic growth factor. So you want to pay attention to these patients who have reduced corneal sensation and either monitor them closely or get them to a cornea specialist. If they have staining that doesn't resolve with lubrication, they need more aggressive therapy because they can go blind. And these patients do very poorly after cataract surgery, especially with topical NSAIDs, this compound that disease. And then we also had a very interesting case of a patient who had neurotrophic keratopathy and trigeminal neuralgia, and their pain improved very dramatically from the trigeminal neuralgia with the use of that topical neurotrophic growth factor. So stay tuned. That may be a treatment coming in the future for our patients who have eye pain, particularly corneal neuralgia.
Thank you.
Thank you. Thank you, Dr. Drew.